over to you, Jain, and introduce and go ahead with the case.
Good afternoon and welcome. Thanks to Dr. Srinivas Kumar for giving us the opportunity to do the live case from KIMS Secunderabad. And today we are doing a live case. The live case what we have selected today is a very interesting case. It's almost a no contrast PCA of RCA using OCT imaging. Okay. So can you show the slides, please?
Here it is.
So these are the case details. Next slide. He is a 68-year-old male, diabetic from 25 years on insulin. He is hypothyroid from 15 years and he had CKD stage 4. He had a psychiatric illness on lithium, clomiprazole, risperidone and triaxafinidine for a long time. He had COVID in December 2021. Next. He was admitted with an acute inferior lateral MI on 12/7/2022 and pulmonedema, and patient had a severe hypotension leading a high vasopressors and uncontrolled sugars. Next slide. So this is an electrocardiogram showing ST elevation L2, L3, AVF and there is a small ST depression in V1 also. Next slide. And these are the posterior lateral lead V7, V8. You can see the ST elevation there. Next slide. So echo showed a moderate mild LV dysfunction, ejection fraction of 45%, a mild mitral regurgitation and good RV function. Next slide. So we counsel the patient. When he came to our hospital, he already said that he had a CKD and creatinine was 3. He was very confident about it. So we counsel the family that in spite of his CKD, we have to go ahead and do a primary PCI. It will benefit him a lot. With the risk for dialysis and with the nephrology backup, we took him for a primary PCI. Next. We did a primary PCI with right radial access and 6 French extra backup guiding was used at the time. And next slide. Can you show that? Now, this is the angio at the time. This is the right radial approach. And to our surprise, it was a severe triple vessel disease. This is a cranial injection where you can see multiple lesions in LAD. And this is a caudal injection. You can see proximal LAD and mid LAD. And there's a total occlusion of proximal circumflex. And that is a culprit lesion. Next. And this is an AP cranial view. Again, you can see multiple lesions in LAD here. Caudal also, you can see there's a multiple lesions in LAD and a total occlusion of the circumflex. Next. Right, we had anomalous origin, so I have to use an Amplatz catheter to hook it to get a good view. I didn't want to use too much of contrast, but somehow I could hook it with Amplatz AR2 catheter. And you can see again multiple lesions in right coronary artery also. But a good distal RCA and PLB, PW is a very good size and normal. There's no disease in that. These are both, we did an RAO and an LAO view there. Next. So these are primary PCA pictures. We crossed with a cyan blue wire. Here we pre-dilate with 1.5 and 2 millimeter vessel. It's a very large vessel, you can see that. And after pre-dilatation, we used a onyx stent here, 2.5 into 38. Next. 30. Yeah, 2.25 into 34. And this is the balloon dilatation. Next. And this is the result we got with the TIMI3 flow. So post-procedure patient was kept in hospital for next 2 days, and though further worsening of creatinine, he didn't needed a dialysis and he was sent home. So today we brought him back to the lab and we didn't want to use more contrast. We're better position. We're not in emergency situation. So we counsel the family that we'll be doing a angioplasty without contrast. So your risk of even though Maran score is 8 with a 14% CNR contrast-induced nephropathy risk, the risk will reduce with using a minimal contrast. Next. This is his present ECG, which is much stable. There's no ST elevation, and there's T wave inversion with ST coving and L2, L3 AVF. Next. Can you go back to what we have done? Can you focus on to the monitor here?
Shows the screen now.
Screen now. Okay. Can you show from the first? So what we use, we have used 6 French MPA catheter, guiding catheter here because of the anomalous, and we are planning to do without contrast. We wanted a good alignment so that we'll not have any problems while doing an OCT run here. Next, we used a cyan blue wire I'll tell some tricks about cyan blue we learned from Dr. Swamy. And he says that this wire is baat karne wala wire. I don't know how many people understand. And it really talks to you when you use this wire. So you should know how to use this wire. And in fact, I've changed all my hardware to this baat karne wala wire. I know no, who is it? No, we have international faculty will not understand this Hindi language. But this is a fantastic wire. We crossed it with it. Next, and then this we did already. Next, we pre-dilated with 2.5, 15, 2 millimeter into 12 millimeter balloon. We did a dilatation there, and we did a little other dilatation here. Next. And then after dilatation, we did an OCT run. And this is just one contrast which I have given. And this is again to see the everything is in place. And after that, we have not used any contrast. Next. And then we did an OCT run here. And Dr. Ajay Swamy, you can just tell us what we have done in the OCT. Any
Sorry
questions
to
till now?
interrupt you. Maybe you could tell us why, so what, for what, from your perspective, was OCT necessary exactly in this point? So because you wanted to know how long the stent should be, or because you wanted to have best information regarding the needed stent diameter? Because normally everybody would go with a stenting as the next step, post-dilatation, maybe to perform imaging just to confirm perfect result. So what was your intention?
Right. So we had 2 points. I wonder if I'm audible. If I just get an indication, I will carry on. Am I audible?
We can hear you.
Right, fantastic. So this is basically the only contrast that you see in the coronary artery is what was used to flush the guide catheter when we have flushed saline to see whether we are getting contrast clearance or not. We have not used any contrast at all. Next, Cine. And if you will see the screen, this is the OCT image being acquired with a saline injection. So we haven't used any contrast whatsoever for the acquisition. The advantage of co-registration along with a saline OCT, it gives us the exact length, the exact morphology, exact diameter, gives us the landing zones, everything. So if you can see the screen, I think you can see the OCT catheter pullback and you can see that there's no contrast at all. Is that visible?
Yes, we can see.
Dr. Padmanabhan, are you able to see the OCT run?
So your intention primary was to have the best possible information from OCT and then to plan stenting procedure and try to avoid to give contrast medium, right?
Yes, sir. We wanted to minimize almost you can tell a zero contrast. We don't want to use any contrast in this patient.
Okay.
So now as you see the OCT run, you can actually see the co-registration indicator moving along the vessel. I don't know if that's visible. Is that visible? The white dot that you see moving inside the RCA. Can we use the arrow? Yeah, play it again from backward from 10. Right, play. Yeah, play. So you can see the white dot moving back and you can see the contrast clearance that we get with saline inside the RCA. The images that we get are excellent quality, they are easily interpretable and it gives us the entire morphology, the length as well as the diameter of the vessels. You can see a little bit of calcium there and there is some lipid plaque as well and lots of fibrotic plaque as we see.
Yeah, we
As
see,
become
I
more
think it's
proximal,
really
this zone is a little less
nice,
diseased.
nice quality, high quality pictures, what we can see now. So finally, how long was the lesion? How long should be the stent and in which diameter? Probably the longest you have 3.0 and 275.
Right. So can we see the distal landing zone that we've identified and take the measurement first distal and proximal? So we identified an area where the trilaminar architecture is clearly visible, and you can see the marker in the distal RCA. Now the measurements that we've got is approximately 2.85 EL to EL in 2 axes. So 275 is what we're going to use, and this is the place where we're going to land it. You can see the marker on the screen. I wonder if it's visible. Can you show the arrow there? Abhinav, show the arrow. Yeah, there. So we mark that on the screen. Come back to the OCT now. Similarly, we come to the proximal landing zone. Come all the way back to the proximal landing zone. Now, this is a proximal landing zone where again we see a trilaminar.
Yeah.
Yeah, very nice approach to
3.1 and a 3.2.
to get perfect information, right? 3 point. So probably you have to go with
so
3.0 and then postulate with 3.5 maybe,
So,
3.25.
so there are 2 approaches. One is to use a 275 and post dilate with a 3, or use a 3 at low pressure and go up depending on what illumin we use. The next thing to see is the nature of the lesion. Can we just see the morphology in the 2 places that we've identified?
Ajay, I think you've shown us very good images over here with the saline and excellent co-registration,
Right.
you know. So we are happy with that that injection of yours. You can give us the length and the diameter that you're thinking of.
Right. So we've already measured the proximal and the distal landing zones. The morphology we found in one place had more than 180 degrees of calcium with approximately 700 microns thickness. Can we focus on that area? A little proximal, I think. Little more proximal. Yeah, you can see some calcium here, but as we come little more proximal, come more. Yeah, so you can see the specks of calcium which are coming, and we intend to modify this with a modification tool, that is the cutting balloon.
So do you do OCT
And,
in all these patients? Even you have a creatinine of 2 point something. I think it's 2.4 or 2.3, and
so
you could have used.
The point of the case was that we are doing OCT without contrast.
I understand.
Using contrast. This is saline.
No, I understand that. Your first one, because of co-registration, you had to use little contrast, and you must have mixed it with saline. But how would IVUS have worked in this place?
No. I think we haven't really discussed that point. We did not use any contrast. The only contrast that you see in the vessel is when we have pushed in the saline.
Yes.
Whatever was there in the guide at the time of hooking. That's about 2 to 3 ml.
So
that's all.
that
there
helped
is
you
zero
to.
Contrast used.
I
hope that point is made.
No, I just want to remake the point. You are saying that you got co-registration just injecting saline, and the contrast that was there in the catheter was sufficient to give you that co-registration. Is that right?
No,
sir.
Does not require contrast.
No.
Co-registration does not require contrast.
Cine run.
Yes, doesn't require.
For the 4th time, it does not require contrast. So if you see the injection now, this is the acquisition of the OCT run. I hope it's visible on the screen, sir.
Yeah, but
so
this is the OCT catheter pullback being shown in the RCA, right coronary artery run. Is that visible?
can you see the screen where we are doing OCT run? There is no contrast. It's just a saline injection.
This is a saline injection.
Yes, we can see, yeah.
Okay.
Right. Great.
So we are using a cutting balloon now, Wolverine 2.5 into 10 to optimize the proximal part of the RCA where we are seeing calcium, so that we will not have any difficulty in stenting that part, and we will get a very good result.
So
for
saline, do you use the Ajay? This is Brian Pinto here. Do you use the injector? Do you use the?
I know, sir.
Do you use the injector to inject?
No, I use my hand, sir.
Yeah. So how much saline do you inject when you're injecting with? Because you got very good images.
So I have a 50 ml.
Yes.
Let's go.
You have a 50 ml syringe.
Sir, I have a 50 ml syringe, and I use approximately 20 ml in each injection.
8.
9,
Okay.
10.
10.
So you have strong hands, huh?
And down.
It's a lot of
Not
pressure.
really, sir. We
No,
are
for
used to
saline
it,
it's less
so
maybe.
It's just a matter of practice.
Yeah. Resistance is less. Resistance is
it's a
less
little
with
less.
saline. Correct.
Again,
So your strategy will be to stent, perform stenting as a focal stenting or to take one long stent?
I think we'll need 2 stents here. We got, from what we saw, it is coming to 56 millimeters. So we're using 38 millimeters, 2.75 alpine, and then
we have to go
8,
9,
12.
12, 13. We'll just hold it there, sir. 1001, 1002, 1003, 1004, 1005, 1000.
So how is the pressure at the moment?
So we are planning to use 2. Yeah, pressures are fine. Little patient is having some cough, so there's a deep engagement of the guiding. So now, once you disengage the guiding, now with the balloon support, I think is fine.
Yeah.
The pressures are fine
They
around
have
100.
recovered now. Pressures have recovered.
So would you now check the result with OCT or would you go now with stenting as next step?
I'd like to do another OCT.
We'll
If
do
that's
another
okay,
OCT.
We will just do another OCT run, make sure that we're all right, and then we can go ahead with the stenting. Any questions? Anything that we need to know?
Yeah, done. Yeah, he has to just hold the guiding.
So, Brian sir, if we're still live,
Pardon?
we're going to take the OCT image and we will see how we can do the
Yes,
co-registration.
yes. The distal
without
part you are going
saline.
to, there is
So
some
both-
calcium there.
Contrast. Right, so we have tried to dilate. I'm going to see if we have got, I don't want to go too distal because sometimes the dissection will progress distally. So I've tried to use the co-registration to try and keep our cutting balloon as proximal as I dare.
So, Dr. Brian, what
Yes.
we did is, the proximal part was more calcium.
Yeah.
And then that we have dilated with a little high pressure of cutting balloon. The distal part, we just made a small dilatation there.
So when you all go with cutting balloon, what is the highest pressure that you all go to when you say high pressure? No, just ask.
Clearance, please? Yes, yes. We are okay? Fantastic. Okay.
So,
I have not injected any contrast. I just check on the live image whether
Okay.
I've got clearance from the OCT, just 2 ml
So
injection.
you're doing the saline injection again?
clear?
50 ml?
Clear.
You go
Yeah,
20.
saline injection
Are you
again.
ready?
Yeah.
Okay. Yeah.
Stop.
This time the image.
So
this
you
is
see,
normal
I've
saline.
just injected
Normal
saline.
No, no alcohol.
Can you show the OCT? Can you little,
Yeah. Let's get this out. So wire is mine.
No, I get it. I get it. But I have been injector.
How much? Let's give another 2,500 heparin. So you can see what he's going to do for co-registration now. He's already done, and you can see what we've got as far as the co-registration is concerned. Is that visible on the screen?
Yes, yes, did you? Yeah.
and you can see the quality of OCT also with a saline. And you can see that the
Cuts by
cuts
cutting
with cutting balloon also. You can see very nicely there.
Yeah.
Both at the distal part and at the proximal part. This is a distal part where we did that cut with a 2.5, 10, just went up to 10 atmospheres. And the next one in the proximal part, we went up to 14 atmospheres.
Okay, okay.
So, but you have
So
now
what
quite
size of
long
wall-
dissection.
What size of Wolverine did you use? Cutting balloon? 2.5? Okay,
2.5.
2.5, 2.5, 10.
okay.
There is a dissection distally. No?
Yeah, absolutely.
Yeah,
Yeah,
they
there
have
is
to
a dissection,
cover.
definitely.
Iatrogenic induced dissection by the cutting balloon.
But in proximal
And the
parts,
dissection is not in the, no, not in the proximal part. It's still in the part where we intend to do a dissection. It's not outside the area we didn't intend to do a dissection.
So let's take a 275.
275,
20,
38
30,
alpine.
40.
So you start now with 275 distally, right?
Right.
Yeah, we'll start distally first.
So the plan is to take a short 275, 23.
Yeah.
Do we
So
need,
that
And then
do we need to
overlap
go to
it
the other
with a
room?
40, with a 38 proximal.
Is Dr.
Let's work fast. It's got a little bit of ST elevation.
we can come back
Yeah, rather
some time.
2.75.
Yeah.
Kar, kar.
So now I want you to do me the co-registration here and yeah, show me the landmark. Yeah, yeah, that's it, that's it, that's it. Very nice. So we will just go nominal with this.
Yeah.
This is my distal landing zone. All right, all
But
right.
that will not be seen here.
No,
Co-registration.
doesn't matter, doesn't matter. We are seeing it here, no?
Okay.
2.7523. Okay.
So we're using 2.7523, the shorter one distally, so that we'll not have any problems in crossing.
I think they've gone to the other room.
Are we live? Can you
You're still,
somebody?
you're still
Doctor?
live. You're still live, Ajay.
Fantastic. So sir, anything else you have to suggest? Anything else you want us to do?
I think you'll have modified the plaque quite well. We are impressed with your saline OCTs, especially with the hand injection.
Fantastic. I just wanted the last one's co-registration to be seen once down below. The previous, yeah, that's it. That's okay.
Yeah.
23. I think we're okay. All right, let's go up. Let's go up. Yeah, we'll just go to 10.
10 nominal, no? Yeah.
We'll stay at 20 seconds for this.
Can you maybe explain how exact the placement will be using this method? So you maybe your mismatch will be, I don't know, 1 or 2 millimeters or less?
Right, so in an ideal world, we would have a very nice, conveniently located side branch with which we could kind of land it. But I mean, if you see the small screen on the right-hand lower corner that you see, that is the landing zone which I have chosen. Let's go up here to about 8 atmosphere. So, but having said that, what you see on the right-hand lower corner, I've got a little longer landing zone. So I have about 8 millimeters to play around. So you can decrease. जैन साहब पैर नहीं हिलाना है हाँ
हो जाएगा जैन साहब थोड़ी देर में हो जाएगा
प्यास लगी है थोड़ा मुंह गीला कर देते हैं पानी नहीं पिला सकते अभी let's take a wet gauze piece and put it in his mouth let's dilate it here so we are now
so
doing
you
what is called balloon
postulate
palpation.
proximal with a stent balloon, right?
That's right. It's rather than post dilatation, it is more palpation. Let's deflate it, sir. This is for 2 reasons. Number one, it will tell us whether we have prepared it properly. It also gives us a landmark as to where we need to land our proximal stent without using contrast. So now I'm going to take beyond this 38 should be all right. Yes,
38.
So let's take some overlap of 4 mm. Yeah. So let's do a 338.
338 alpine.
Let's do a 338.
So what will be your choice now?
We have given him the
of next stent?
isn't it? The next stent is 338.
38 alpine. Yeah. I think if what my request is to the chairperson there, once we stand, if you can allow us to show the OCT also, it will be very good. So that the most important point is after stenting, we want to show the result by OCT. So that you can appreciate that
of course,
these type of procedures can be done with almost zero contrast. So I request to continue to screen us live. I think we have another 10 minutes. I think we should allow us to do the work.
Okay, okay.
Chinna, I want to see the previous stent inflation cine on the screen, on top, the landmark. Yeah.
So what you use here is Stent Boost to have...
Yes. We'll use Stent Boost. Yes, yeah.
Yes, we will. Absolutely.
Stent Boost.
Let's magnify it now.
Magnify.
It a little bit.
Stent Boost.
Are we ready for stent boost?
Yeah, go for Stent Boost. Overlap ज़्यादा है. नहीं ठीक है. Can you give that co-registration marker proximal? Yeah.
Raja, have you already inflated it?
No.
Sure.
No. कैसे inflated? No.
Let's do another stent boost, and I want the co-registration marker. Jain sir,
हिलाने 2 मिनट मिलाने हो गया अभी.
ये बहुत important है. इस बार में आपने नाक में खुजली वो सब हम कर देंगे. आप बता दीजिए हमको. Are we ready for stent boost? Yes sir, ready.
చిన్న రావడం లేదు.
Get it. Yeah, I know. I have come up proximally. I saw your landing zone. Stent boost is not ready, Chinna.
Okay, so if you implant the stent,
change
you
Go
can...
back to
You know what we'll
demarc
have,
this.
Ajay?
Demarc this.
We will have to go right now.
Yes, sir.
You'll do the OCT, and we'll come back to you. You know, then you show us the OCT.
Okay.
Okay.
Super.
Yeah. So we have to switch, I think, to Dr. Praveen Chandra.
Okay, so you are now back, and you could show us now the OCT pictures immediately after implantation of the second proximal stent.
Dr. Ajay, you are live.
Can you go back to the stenting? I think
Thank you, sir.
I think we left before stenting or after stenting. Where did
The
we leave?
proximal stent was being deployed. We left
Can you go
at that
back?
time.
Okay. Can you go back to the proximal stent? Yeah, proximal stent.
Next. Yeah, this is the proximal. This is where we left you. Is that right?
We left here.
Yeah.
Next.
And the proximal stent is again Alpine 3 into 38. Next, and we inflated nominally here. Next. And then
Next. Keep going, Chinna. Next. Yeah. We just did the overlap.
So you had
Then we
probably
did
1
overlap with the
millimeter
three,
overlap, and then you implanted the stent, and
yeah.
you performed post-dilatation and then OCT.
Yeah. So we used again 3 into 15 euphora here to post dilate the stent. 2.75 we dilated nominally, and wherever the 3 millimeter stent overlap we went up to 14, and the proximal part we went up to 16. And next. And then we did a OCT. Again, you can see.
Can
the
we
OCT
see
is
this
without
OCT?
Contrast here, the run. Yeah, we'll show you the OCT here.
Play it on full screen, please.
OCT.
No,
Full screen, yes.
Is it visible now?
Yeah, it looks nice with full stent expansion. Some prolapsing parts of dissected areas, but it looks, I think, very, very nice. So do you believe there is one more post-dilatation needed? Not really.
So we have actually gone up to 16, 18 atmospheres with a 3 millimeter. More than this, I think.
There's a mid part of, yeah, exactly from overlap starting here.
Yeah.
But it's, I think it's still a very, very good result. So I personally would suggest to leave it.
Yeah.
So we'll take your suggestion.
You cannot improve much more, but you can make perforation, and this will be disaster.
Yeah.
That is exactly our thought, and that's what we have left it with.
So what was your plan? So you was...
So the total contrast we used only was 5 ml, was just to see the parking of the wire into the distal RCA. That's the only contrast used, only 5 ml was used. After that, we didn't use contrast.
They use very little contrast only in the beginning. That's what they want to say, and that.
That's 5 ml, yeah.
Yeah. So this was very well done with such a
Yeah, I
little
think so,
contrast,
yes.
you know. Yeah. So are you done now? Can we, Ajay?
Yeah, we are done. We are
Yeah.
done. We are done with the case.
Congratulations. I think that was a wonderful case. We need to
Thank
give you a big
so
hand
much.
for this. Thank you.
Well done and nice demonstration. How to approach with practically zero contrast. And now we switch to...
Thank you.
Thank you so much. Great case. Thank you.
Thank you. Thank you. Thank you. Thank you.